Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we're talking about pulmonary hypertension. Hypertension is the medical term for high blood pressure. It's most commonly used when referring to the pressure inside systemic arteries, which are the vessels responsible for carrying blood with its oxygen and nutrients from the heart to the rest of the body. That's the blood pressure you can feel by checking for a pulse in the neck or the wrist, and that can be measured easily with a cuff around the arm. But there's another circuit of blood in the body from the heart to the lungs that operates at a different normal pressure. That separate circuit can also develop an elevated pressure, which doctors refer to as pulmonary hypertension. That can lead to a host of serious health consequences. To guide us through this complex but important topic, we're joined today by Dr. Leigh Altschul. Dr. Altschul is the director of the Pulmonary Hypertension Program for Northwell Health. She's also an assistant professor of medicine at the Zucker School of Medicine at Hofstra Northwell. And I'm delighted to say, Erica, welcome to Well Said.
Thank you. I'm happy to be here. I'm always excited to talk about my favorite topic.
Oh, good. All right. Well, then we're going to have a good time. So let's start by talking a little bit in greater detail about the normal circulation, which will help us define some important terms. So let's start by having you trace the normal path of blood through the body.
This is something that I commonly do with my patients in the clinic, and I tend to be someone who favors drawing. I think a picture where you can go through it is worth 1,000 words, but I will try to use just my words here. A little limited. But what I will say is we want to think about this whole thing as a circle. So the start and end point doesn't really exist, but to explain it to you, we'll start in what's called the right side of the heart. So the right ventricle is the main chamber of the right side of the heart. That's going to send blood through the pulmonary arteries into our lungs. And then the main reason for sending blood into our lungs is, that's where we pick up oxygen and where we eliminate or get rid of CO2. Now you have this nice oxygen-rich blood that we got from our capillaries in the pulmonary small vessels. And then that oxygenated blood is going to drain into our pulmonary veins, and that will go into our left side of the heart. That left side of the heart, or the big muscle there is the left ventricle, is going to send blood through your aorta, and that goes to your whole body. So the top of your head to the tips of your toes, that's where the blood gets sent to. Your muscles and your cells, they use the oxygen and nutrients that you already mentioned. And then your venous circulation sends all the remaining blood back to the heart with any little bit of leftover oxygen, the CO2 that it picked up, and it brings it to the right side of the heart, goes into the right ventricle, and then that exits again through the pulmonary artery, and we constantly go around and around in this circuit. It happens whether you're aware of it or not, and it's kind of a miracle in my eyes.
Yeah, well, no, that's great. And I think you did a wonderful job explaining that. I actually drew a little circle as you were talking, so I hope our listeners did too, and I think that was very helpful. Just to orient us a little bit more, that connection between the left ventricle, the main pumping chamber on the left side of the heart, and the body, the muscles, the brain, the gut, all those other things, that's the area where we think of blood pressure usually being, right? That's the blood pressure that the doctor measures in the office with a cuff and that you can feel in the pulse. And the pressure that you and I are going to spend some time talking about is the pressure that's driving the blood from the right ventricle into the lungs.
Yes, exactly. So we call that, the medical phrase you probably hear is a systemic blood pressure. And so that's just the body systems, all the blood vessels that come off that aorta. That's what it supplies to. That's the blood pressure that we're really talking about when you get your blood pressure checked at the doctor's. That's very different, or it's supposed to be, in an ideal world, very different than the blood pressure that is happening inside the lungs. So we know that when we develop, and if we think about that circle that hopefully everybody drew, the same amount of blood that has to just go from that right side of the heart in your chest to the lungs in your chest, that same amount is being sent to the whole body. So how is it that the lungs are able to accommodate that same cardiac output, how much blood the heart is pumping out, all going to the lungs, but then also all going to the whole body? And the only reason it's able to do that is that the lungs are supposed to be a very low pressure, compliant. So think about a balloon that you blow up. It expands very easily. We want it to accept a large amount of blood flow that otherwise has to go all over the place in the rest of the body. So by keeping that pressure in the lungs low, the blood can move through very easily.
Yeah, so let's put some numbers around this. So I think most people are probably familiar with the fact that a normal pressure in the systemic circulation is about 120/80. So what's the normal pressure in the pulmonary circuit if we're talking about blood going from the right ventricle into the lungs?
Yeah, we usually look at it to be about 1/10 of what we see in the systemic circulation. So a typical number that you should see for normal pressure inside the lungs is about 20 to 25 over 10 to 12. So they have the two numbers, one's called your systolic and one's called your diastolic. And to make it simple, we'll say 25 over 10 is what should be normal in the pulmonary circulation.
And again, the reason why it's so much lower in the pulmonary circulation is so that the right ventricle doesn't have to work so hard to pump all of this blood through the lungs.
Right, exactly. It's got to accommodate a very, very high amount of volume, and to do that, we usually want a lower pressure circuit versus the systemic arteries. They have to send blood much further away from the heart, so you need these stiffer vessels to keep pushing the blood against gravity, right? If we're standing up, our head is above our heart. How do we do that? Well, we have these higher pressure arteries that keep the blood moving forward. In the chest, it's all contained in this one limited cavity, and so you want it to be lower pressure with thinner vessel walls to accommodate all of that flow.
Right, and as a consequence, the right ventricle, the pumping chamber on the right side, is not as muscular or strong as the left ventricle.
It doesn't have to be. It's not supposed to be because it was built to just send blood to a very short distance.
Okay, so I think we did a pretty good job of setting up the normal. I want to talk a little bit about how this kind of gets off the rails a bit. So when we talk about systemic hypertension, we often talk about different stages or degrees of severity. Is there an analogous scale of severity for elevations of pressure in the pulmonary circuit?
Yeah, this is a really interesting question. We don't have as definitive cutoffs as saying this is mild, moderate, severe pulmonary hypertension. It can be very variable depending on what source you look at. What we really look at for pulmonary hypertension is what the effect of that high pressure is having on the function of the right side of the heart, as well as the function of the person. So we tend to use risk stratification when we're looking at pulmonary hypertension to see how much is it impacting you being able to get up and do your laundry, walk up a flight of stairs. How can you get through the day, or is it really limiting you? We've learned that the absolute pressure is not quite as important in disease severity than the impact of that pressure on the person and on the heart.
Why is that? Is that just a matter of differences in how people's hearts and lungs adapt to the whatever's causing the elevated pressure?
Yes, that's exactly right. If we look at pulmonary hypertension, I always try to explain to people that this is really an umbrella term. And so you're going to learn all my little drawings and quirks that I do in clinic, but I actually draw out an umbrella.
I'm so sorry we can't give you the opportunity to draw.
It's all I know how to do. I grew up with my dad, who's a cardiologist and an artist, and everything he taught me was through drawings, and now it's how I best teach my fellows. But if you were to draw an umbrella and you give the umbrella, we'll say 5 little spikes, how you have your rounded umbrella at top and the 5 at the bottom. I write pH in the umbrella, and then underneath that umbrella are all the different things that can cause pulmonary hypertension. And there's 5 groups of pulmonary hypertension. Those are each group its own bucket of different diseases that contribute to the pressure being high. And what really impacts it is how quickly did that pressure increase. So if we take, for example, one of the groups is going to be something called Group 2 pulmonary hypertension. It's the most common group, and it's due to left-sided heart disease. That's about 70 to 80% of patients have high pressure in the lungs. If you think back to our circle, if pressure is high on the left side and blood is going from the lungs into the left side of the heart, well, that's going to reflect back, and that's going to cause disease. And what we see is that those patients can have quite high absolute numbers of pulmonary pressures, but they've had time to accommodate. It's a reflection of what's happening on the left side of the heart, in the body, and that may not be as severe as, let's say, a younger person who has the one that we're mostly concerned about is this Group 1 pulmonary arterial hypertension, and perhaps they have it from a connective tissue disease like scleroderma, and the rate at which the pressure starts to go up over time is faster. The impact on the heart function on the right side is greater. Their absolute pressure might be lower, but the overall resistance of the circuit is actually much higher. Patients are more symptomatic, and we have to get them a more aggressive treatment.
Okay. Well, I think that's a really interesting way to look at it. It's both the tempo and the absolute value of the pressure, which, again, speaks to the body's ability to adapt to whatever abnormality is driving the pressure up in the first place. So you mentioned two kind of groupings of causes of pulmonary hypertension. The first being more common diseases of the left side of the heart, and then this second one. Could you run through the other categories just so we get sort of a complete census of what causes this?
Yeah, I think that's a great idea. And I'll start back at group one. I think it's just easier when you go in numerical order and we sort of recap. So group one is unfortunately the one where most patients, when they Google pulmonary hypertension, this is what they're going to read about. And that is actually a question, kind of another side note for me. I ask all my patients when they come in if they've Googled pulmonary hypertension, because it can take you to certain resources. It's usually talking about this specific group, and it can be very scary to read about it. And I need to know where your head's at, because if you're really anxious, you're going to hear maybe 10% of what I've said, and maybe I have to spend the visit walking us back off that ledge, so to speak. Sure. But group 1 PAH is kind of why I exist. It's the group we don't want to miss. It tends to be younger patients. It tends to be female patients, and there's certain risk factors that can put you into group 1 pulmonary arterial hypertension. But all in all, it's saying that the real disease stems from disease of the pulmonary arteries. It used to be called primary pulmonary hypertension. It means that that's where the problem is stemming from. It can be genetics. It could be from certain types of connective tissue diseases like scleroderma that I mentioned. It can be from portal hypertension, which is a type of liver disease. There's infections like schistosomiasis and HIV that can be associated with it. There's congenital heart disease. There's a familial version of it. Unfortunately, there's a pretty common version called idiopathic, which really probably represents a group that we haven't figured out yet why they have it, or it's a combination of a genetic predisposition without the actual gene mutation, or we call it a double hit phenomenon. You have two exposures. Certain drugs can lead to it, like methamphetamine or certain chemotherapy agents or the diet pills, fen-phen from back in the day. So something predisposes you to develop it, and you get significant disease of the lung vessels, which leads to right heart failure. That's that group 1.
What percentage of patients in general with pulmonary hypertension would you say have that group 1 type of?
Yeah, if we look at the whole umbrella of pulmonary hypertension, it's going to be less than 10%. The majority of patients are going to have this group 2, which is that left-sided heart disease, and that could be an array of left-sided heart disease. You know, heart failure with preserved ejection fraction. This HFpEF is a fun term that you're probably going to hear about. That's stiffness of the heart versus heart failure with reduced ejection fraction. That's going to be the pumping is really down. Or you have a valvular heart disease or atrial fibrillation, the irregular heart rate. If you have high blood pressure, if you have diabetes and obesity, and we'd see that can also lead to more stiffness of the heart. There's different types of cardiomyopathies. Anything that causes pressure on the left side of the heart to increase can reflect back and cause pressure inside the lungs, and then on the right side of the heart to increase. And then the other most common, a little bit less than our group 2, that is about 70 to 80%, but often overlaps with much of our group 2 disease, is group 3, which is due to chronic lung disease. So your COPD, your emphysema, if you have fibrosis of the lungs, if you have severe sleep apnea, if you live in a high altitude and you're constantly exposed to low oxygen levels, all these things can work together and can cause pressure inside the lungs to be higher, primarily from having low oxygen due to lung disease. Group 4 is going to be this fancy, we love our big long term, so this one's a mouthful. It's chronic thromboembolic pulmonary hypertension.
I was waiting for that. Okay, keep going.
We call it CTEPH for short. That mainly makes up group 4, but it's really anything that chronically obstructs the blood vessels. So the way I describe this is, think about you're driving on a highway and then suddenly they close down 2 lanes. And what's going to happen? Well, all the same cars, aka all the same blood, have to travel through now these closed lower number of lanes because these other lanes are closed down. Well, it's going to back
there's
up.
More traffic. Right.
There's more traffic, means there's more backup, there's more pressure inside the lungs, and it reflects on the right side of the heart. And then group 5 is kind of the funniest, in my opinion. We sort of call it other. It's this fun medical way of saying we're not sure entirely why patients get pulmonary hypertension, or it's more of a combination. It can be somewhat of a group 1 physiology and a group 2 physiology, and there's many different reasons why. So that kind of becomes this miscellaneous bucket of things like sarcoidosis or glycogen storage diseases. There's certain types of hemolytic anemias that can cause it. Chronic kidney disease can cause it. It's really just this sort of miscellaneous bucket.
Yeah, kind of a whole grab bag of things. That was a terrific summary of all the different causes of pulmonary hypertension, and I imagine the therapeutic approach is going to be very different depending on which category somebody falls into. So let's back up a little bit and say, well, what kind of symptoms would bring somebody to medical attention so that you can do your work and figure out which bucket somebody goes into? So what do people who have pulmonary hypertension experience?
I do want to mention probably the most frustrating thing about treating pulmonary hypertension or even diagnosing it. It's very nonspecific. So one of the things that we have not really done better on, despite having significant number of medications that have come out in the last 25 years when there used to only really be one. We've made a lot of strides in coming up with treatments, but we have not decreased the time from symptom onset to diagnosis. And why is that? Well, because the symptoms I'm going to give you sound like any other heart or lung disease that happen to be much more common than pulmonary hypertension. So, of course, if you don't have blood flow going easily to your lungs and through your lungs, well, you're going to be short of breath. You may start to feel a little dizzy because you're so short of breath when you start to walk up the stairs. You may notice some palpitations, like your heart's beating really fast when you're exerting yourself that it didn't to do before. You may really start to see swelling of your legs or even some bloating. Your belly feels a little bit bigger. You think you're just putting on weight because you're getting older, and you just feel sluggish and fatigued and tired. Those are unfortunately the most common symptoms of pulmonary hypertension, and that can describe anyone with emphysema, with high blood pressure, with left-sided heart disease.
Right.
They're all very nonspecific.
Yeah. So, I was thinking as you were running through the list that you've just described everyone who comes to my office.
Right, exactly.
So I guess the next question is, so how do you then make the diagnosis? What do you do to evaluate somebody and tease apart, well, in this patient, those symptoms are being caused by this abnormally high pressure in the pulmonary circuit?
It's really making sure that the doctor has a high clinical suspicion, meaning that they've ruled out the common things. So I will always say if you're short of breath, we should make sure you're not having something like coronary artery disease or uncontrolled blood pressure. But if we start to look at things like an echocardiogram and we see on this ultrasound of the heart that the pressure in the pulmonary arteries, which they can measure, and it's not a perfect science, and I don't want to insult your echocardiograms, it's done an incredible thing for pulmonary hypertension, but it is an estimation of pulmonary pressures. But it can give an idea that the pressure could be elevated, or because we can't always get a good measurement of that pressure, we can see things on the right side of the heart that suggest, hey, this right side that you mentioned is supposed to be thin-walled, it's supposed to be small, it's not nearly as big as the left side. Once you start to see that it's thickened, or we call it hypertrophied, if it's dilated, if the right atrium is also dilated, or the valve on the right side, the tricuspid valve, looks very leaky, these things can be seen by your cardiologist to suggest there's strain on the right side of the heart, and then we have to think of, well, why is that? And as soon as you have that clinical suspicion, you want to be thinking about the risk factors for pulmonary hypertension. Is it just left-sided heart disease that I haven't been able to be as aggressive with my treatment, or do I want to look more into this? And we always favor, if you're seeing it and you're not sure why it's there, send to a pulmonary hypertension center, because unfortunately, as much as I put all of these groups into their pretty little buckets, patients don't follow textbooks. Patients don't follow buckets. A lot of patients have overlap of different causes, and that can make it really hard to figure out pinpoint what to treat and what the next steps are. So just getting them to a center where this is all we do every day is the best way to decrease that time from symptom onset to diagnosis. And
at that center, so you're going to be asking all of those questions about whether they have signs and symptoms of other systemic illnesses like connective tissue disease or sarcoidosis or something like that that could be playing a role here. You're also taking a careful family history to see if there's some genetic component. What other tests are you doing to confirm that the problem really is an elevated pressure in the lungs or the arteries going to the lungs?
Yeah, we have what we consider our non-invasive tests, and then we also have our gold standard diagnostic tests. So in terms of the non-invasive tests, obviously echocardiogram is usually the first place we're starting to suspect or see pulmonary hypertension. And then we're, based on your risk factors, going to maybe tailor some of the studies, but almost everyone's going to get a scan of their lungs to rule out that fun CTEPH, chronic thromboembolic pulmonary hypertension, and that can be something called a VQ scan or a CT scan with contrast. We just want to see the arteries and make sure that they're all patent, that the lanes are all open and blood is getting there. Everyone will get pulmonary function tests. You don't want to miss something like a restrictive lung disease or a fibrotic lung disease or emphysema, COPD, because that is something that we would then have to go down that route and figure out treatment plan. We're going to, or at least I should say, I like to always send my patients for a 6-minute walk test so I can see what is your body doing when you exert yourself. Are you really limited in how far you can walk? Is your heart rate shooting up? Is your oxygen dropping low? Is something driving this that I can really pinpoint and say, oh, yeah, there's definitely something to suggest that you're being strained. It's also a marker we follow as we treat, so I want to show that your 6-minute walk test has increased. We're sending blood work, so those connective tissue disease will send serologies, which tell us whether there's any evidence of antibodies or certain types of conditions. I really love something called the NT-proBNP. That's an enzyme your heart releases when it's strained, and that can tell me, as part of our risk stratification, how much is the heart suffering potentially with this pulmonary hypertension. And then really everyone with pulmonary hypertension should get a sleep study. We know that obstructive sleep apnea increases the risk for pulmonary hypertension. We also know that pulmonary hypertension worsens obstructive sleep apnea. So it's a bit of a chicken or the egg where we have to figure out what's causing it, but everyone should be tested for it, especially because it can be so easily treated. And then for the patients that we feel like either are very high risk for being group 1 or they have multiple factors and we're not sure what's driving it, or even if we're really convinced, hey, this is a group 2 pulmonary hypertension, but it feels out of proportion. I don't know why it's so bad. I don't think the left-sided heart disease is all that bad. The gold standard is a more invasive test, not a surgery, called a right heart catheterization. And that's where we go in we take a small needle, we get into one of the major vessels, and there's 3 different vessels, or really 4, that you can use to approach and get inside the main tunnel or highway to your heart. And it takes us down into the right side of the heart and into the lungs. We measure the pressure, we measure the heart function, we calculate something called resistance of the circuit, both the pulmonary and the systemic, and we can even do provocative maneuvers. We can give medications to try to lower it. That's called vasoreactivity testing. We can give fluid. We can exercise you. There's a lot we can do to see what is your body's response to this high pressure.
So that's a lot. Say a little bit more about the 6-minute walk. How is that done?
It's a very simple test, which is why I like it. We have a hallway, we measure a specific distance, and we basically just ask you to walk up and down that distance wearing a little pulse ox monitor, which we can check intermittently to see what the heart rate and the oxygen is. And we say just walk as briskly as you can. If you have to stop and rest, no problem, but I want to see how much you can do in 6 minutes.
In people who are impaired, that can show a real inability to get very far in 6 minutes.
Yes, it is very effort dependent, right? So there's a lot of limitations to just saying, hey, let's walk for 6 minutes and then look at the absolute distance and say this represents something. Let's take somebody who is in their 80s and just had their knee replaced and is just getting back into walking. That'll be very different than my 35-year-old who's coming in. But overall, it's something that you can use as a marker. I also like to look at heart rate response to exercise, heart rate recovery to exercise, and blood pressure response to exercise. So all of us should have somewhat of an increase in our blood pressure, especially the systemic, when we're pushing ourselves or exerting ourselves. If that blood pressure drops when you're exerting yourself, that's a pretty poor prognostic indicator to me.
Bad news, right. Right. So again, all of this is intended to give you some insight into just how symptomatic somebody is, how well they're able to compensate for whatever abnormality they have, and it gives you some important prognostic information.
Right, exactly.
Yeah. So now you've done all of this testing. What is it that you can offer patients who are symptomatic, they're short of breath, they have some inability to be as active as they'd like to be, and you've identified one or more causes of the pulmonary hypertension? I mean, obviously, you're going to, if there's a specific illness that's causing this, you're going to treat the underlying illness. But is there something aimed directly at the pressure in the pulmonary artery that you can offer?
Yes, this is not an easy question to answer. I tell everybody that it's more like Goldilocks rather than a one-size-fits-all. So we have to figure out the right regimen that works for you. It's going to be very dependent on the phenotype, which is which bucket or buckets do you fall into, and what do we think is the primary driver of your symptoms and of your disease. If we do feel that it's this group 1 pulmonary arterial hypertension, then we really want to be aggressive with what we call pulmonary vasodilators. So there's 4 different classes of medications now that we can give for pulmonary hypertension. And for most patients, even if they're low or intermediate low risk, we're starting with what we call upfront dual therapy, because we have data that shows if we are more aggressive at the start, patients tend to do a bit better. Our goal is to move you into a low-risk category, and do that by improving that BNP enzyme we talked about, improving your 6-minute walk distance, improving your functional capacity and how well you can do things. And I'll be more aggressive depending on how aggressive the disease is. It can be as significant as being on 4 different medications that range from pills as well as a continuous infusion, so kind of our big gun, the strongest med that we have for pulmonary arterial hypertension is a medication that can be infused through an IV or a subcutaneous pump, and that means you're constantly getting the medication and you are hooked to a pump. It's a big deal, and we don't take it lightly to alter your whole being, but when it's necessary, understand that we're only doing it because we think that you're someone that would really benefit from it. But there's side effects to medications that we have to take into account, and it has to be catered to what you're capable of doing. It does me no good to put you on a strong regimen of different medications that just make you miserable and then you stop taking them. I haven't helped you if we've done that. But there's newer medications. There's an injection that goes into the skin that's once every 3 weeks that has had very promising results. That's called Sotatercept or Winrevair, if you've seen any in the ads. And we do a whole combination. We adjust. We titrate the medications. We become very good friends because I see you in follow-up very frequently. We're repeating tests, and we're trying to get you where you can coast, feeling well, doing what you want to do, and minimizing the effect on the heart.
Yeah, and I think our listeners may be surprised to learn about one class of drugs that's used for pulmonary hypertension. I'm sure you know what I'm thinking of.
I do. I have to explain it all the time. So you're referring to sildenafil.
Here's your chance to explain it again.
Yeah, no problem. Sildenafil is a pulmonary vasodilator that really was made to treat pulmonary hypertension. It had this effect of giving men unexpected erections, and now it's gotten a lot more money and a lot more advertising for being Viagra or Cialis, but it's a very well-used and common, easily tolerated drug for pulmonary hypertension. And so it is funny when I tell patients they're going to go on this. I used to when I first started practicing, I wouldn't even mention the Viagra thing, but I would get so many calls or comments on follow-ups of, why did you put me on Viagra? That I've now feel the need to explain in the very beginning.
Yeah. And so it's just, there is some sort of underlying common physiology that explains its effect on both, right?
It improves blood flow.
There you go. Okay.
to many different areas, primarily the lungs, but also other areas.
Okay. So we've obviously just touched the surface of a lot of different paths that we could go down here, and I really appreciate how clear you've been in explaining the whole landscape. I guess my question to you is, where do you think the future is in your ability to have a positive impact on patients with pulmonary hypertension?
I think if I can make the biggest impact, it's actually going to be in education, because it really depends on early recognition. And so we need to educate patients to advocate for themselves. You know, a common story that you will unfortunately hear if you practice pulmonary hypertension is the young woman is told she has asthma, she has anxiety. Younger people can compensate pretty well for heart disease up until the point that they can't. So we tend to find those patients later in disease process. Part of it is that young people don't want to be sick and don't recognize their own symptoms and maybe have a little bit of a denial about what's going on. Or doctors also have a bias and say, you're young, you're healthy, you shouldn't have a disease. And so there needs to be this lower threshold for patients to say, hey, this doesn't feel right, or what you're complaining about seems to be more than just anxiety or asthma, and let's have a lower suspicion to get an echocardiogram. You know, that is a pretty easy to do, non-invasive study,
yes,
and it can tell you a lot about what's happening inside the heart. And you can be reassured that it's probably not significant pulmonary hypertension if that heart looks normal and the pressures are being measured as normal. I also think that it's going to be understanding that there are a lot of treatments. There's this negative, preconceived notion about pulmonary hypertension that it is a death sentence. I mean, the number of patients that have come in and said, am I going to die in 3 years? Because data takes time to collect, right? If you're looking at 10-year mortality outcomes, well, you need to be looking at it for at least 10 years and then analyzing the data. So all of our outcomes data are going to be behind where we're at now. And the fact that we have multiple medications and that it doesn't need to be a one-size-fits-all, to develop a good rapport with your patients to say, let's work with this together and figure out what fits your lifestyle, what fits your disease, and makes you better. It's not just slapping on meds and saying follow up in 6 months. And so I want to have that rapport with you. I want to give you hope. It's also very important that I'm honest when the disease is end stage, and we can recognize our limitations as doctors, that we can't do anything more, and be upfront and honest about that as well, and walk you through the process of a heart that's failing. But what I want to do is catch you early when you're in that low risk and get you on medications and keep you in that low risk profile. The most severe disease will end up in heart failure or in transplant. And if we can avoid getting to transplant, obviously that's our goal.
Yeah, I think this has been a great conversation. I really appreciate your knowledge, expertise, but also the clarity of your explanation. So thank you so much for coming on the show today.
Thank you for having me. I'm really excited to know that people want to talk about pulmonary hypertension. I always joke that the right side of the heart is the forgotten ventricle. We want to make sure.
I'm so glad we gave you the chance to even the score here a little bit. My guest today has been Dr. Leigh Altschul. Dr. Altschul is the director of the Pulmonary Hypertension Program for Northwell Health. She's also an assistant professor of medicine at the Zucker School of Medicine at Hofstra Northwell. Thanks also to our producer, Lois Bentavenia, our editor, Edward Lee, and our audio engineer, John Mullen. For more information about this particular episode and to find all of our past episodes, please visit our website at medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send their comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.